Good afternoon from Switzerland, good morning or good evening to participants worldwide, and welcome to this webinar on osteoporosis primary prevention and treatment, care gaps, and impact of COVID-19 on assessment and treatment. My name is Emma Greiswood. I'm the External Development Coordinator at IOF. Before introducing the chairperson, I would like to inform you of a couple of housekeeping points. So all attendees are automatically muted. I would also like to encourage you to ask questions during the webinar by typing your questions into the question box of the control panel. Questions will be voiced to speakers towards the end of this webinar. This being said, I'm happy to introduce Professor Nicholas Harvey, Professor of Rheumatology and Clinical Epidemiology at the MRC Life Course Epidemiology Unit, University of Southampton in the UK, and chair of the IOF Committee of Scientific Advisors, who is going to chair this webinar. Professor Harvey, welcome, and the mic is yours.
Great. Thank you very much indeed, Emma, and my thanks to Emma and Dominique, also in the IOF office, for their support in getting the whole Bonecast series organised. So it's a great pleasure as the chair of the IOF Committee of Scientific Advisors to warmly welcome you to this webinar entitled Osteoporosis Primary Prevention and Treatment, Care Gaps and Impact of COVID-19 on Assessment and Treatment. And I'm delighted that this has been supported by Amgen, and our sincere thanks to the company for that support. So we have two presentations, the first to be given by Professor Eugene McCloskey from the University of Sheffield, and secondly from Dr. Joseph Blanch Rubio from the Hospital del Mar in Barcelona, Spain. And what we'll do is have our first presentation from Eugene, and we'll follow that with some specific questions just on that topic before moving to Dr. Blanch Rubio, and then some specific questions on that. And what I hope is that at the end of the session, in the remaining 10-15 minutes, is that we'll have chance to have a more detailed general discussion around the impact of COVID and the way forward. So without further ado, I will just hand over to Eugene McCloskey. We very much look forward to what you have to tell us about the burden management threats and opportunities associated with fragility fractures in Europe. So Eugene, over to you. And you're muted at the moment, Eugene, I think.
There we go. Thanks, Nick. Can you see my slides okay?
They're on the presenter view rather than the other view. That's it. Perfect.
There we go. Okay, thanks, Nick, for the technical check. Thank you very much indeed. It's a pleasure to take part in the this afternoon's webinar, and over the next 15 minutes or so, I just want to sort of set the scene by reviewing some updated data on the burden of osteoporosis in Europe, and talk a little bit about the threats and opportunities that arise in the near future for all of us involved in the day-to-day management of patients with osteoporosis and osteoporotic fractures. These are my disclosures. So many of you will be aware that at the beginning of the last decade, there was an exercise undertaken by the International Osteoporosis Foundation to look at the burden of disease of osteoporosis in Europe and to identify the gaps at that time. And this was called the SCOPE project. And that project led to a number of outputs, some of which are shown here on the slide. There were a couple of papers back in Archives of Osteoporosis, an overall summary document, and then individual country reports that were really designed for the individual country physicians and those involved in policy work to be able to present to the governments, departments of health, and others the burden of osteoporosis, how the country was performing in relationship to surrounding or neighbouring countries, and to try to stimulate activity in dealing with the osteoporosis burden. So more recently, we've started to update that exercise, and a scope 2 analysis is underway and will be available shortly for publication. As a preemptive move to that, we undertook an update of the burden in the EU 6 countries that are shown on the slide here: that France, Germany, Italy, Spain, UK, and Sweden. This again was published last year. So again, this is there as a research document for you to refer to. And I'm just going to show you some data from that in the next few slides about what we know, what has changed, and what we can project forward into the future in terms of the burden of osteoporotic fractures. So this is just looking at the number of fractures on the left overall in the EU 6 countries by age group from 50 up to 85 plus. The orange bars represent women and the blue bars represent men. And you can see that there's, as expected, a stepwise increase in the prevalence of osteoporosis by age. And on the right, you can see that this is just looking at the absolute number of new fragility fractures in the year of 2017 when this survey was done. And you can see that the burden of fractures varies across the countries, largely related to the size of the population of each of those countries. But we're looking at, for example, 500,000 new fragility fractures in women in Germany in 2017, about 250,000 fractures in men in the same country. And you can see that the pattern of male to female fractures is very similar across the different countries, as expected. In that project, we were also able to look at the performance of fragility fractures in terms of the disability that arises, and that's expressed as disability adjusted life years. And this is the number of disability life years in the EU 6 across a range of conditions. And you can see that they're ranked here from the highest burden with ischemic heart disease at the top to multiple sclerosis at the bottom. Obviously, a smaller number of patients, but still severely affected. But you can see that fourth on the list here is osteoporotic fragility fractures, and the burden of disability that arises from those is greater than the burden of disability arising, for example, from COPD, from stroke, from osteoarthritis, and so on. So the burden of disease is real, it's quantifiable, and it ranks high amongst the burden arising from chronic conditions in the EU 6. Not only that, but as I mentioned, we can predict forward how things might change between now and 2030, so at the end of the present decade. And you can see across the 6 countries here, France on the left, Sweden on the right, you can see that each country is, as expected, perhaps going to see a further increase in the number of fragility fractures over the projected 13-year term between 2017 and 2030. And that increase is of around 20 to 25% across all of the countries. So it's a burden that is high, it's a burden that is going to increase, and it's a burden that not only comes with costs for the individual patient, but comes with costs for society as well. And that economic cost of fractures is shown on the next slide, and you can see that the burden of costs is much greater for hip fracture than for other fractures. And we know that because of the age of the patients, the hospitalization rates for hip fracture, the comorbidities, and so on. But again, the pattern is very similar across the different countries. The costs are going to increase in a parallel fashion to the increase in fragility fractures. Not identical, because the costs are projected to increase slightly differently in some countries compared to others. But as I mentioned before, it's not just a burden of fractures, but it's the burden of costs that are associated with management of those fractures, and reiterates the need for us to try to do better to decrease the burden of fractures. But there is, as we might expect, a treatment gap in osteoporosis. And there are two sources of data on the slide here, which I will go through. On the left is the EU6 report, and on the right is what we call the 129 study, which I'll describe in a little bit more detail in a moment or two. Both these exercises were undertaken looking at individuals at increased risk of fracture, and that was really based on the presence of prior fracture, probabilities of fractures above country-based thresholds for intervention. And that population that was identified was then in the EU6 study compared to the proportion that were assumed to be exposed to anti-osteoporosis treatments based on treatment sales. And you can see that actually there's fairly marked degree of uniformity across the different countries and disappointingly high treatment gaps. So for the whole EU6, in women identified at high risk of fracture, 73% were untreated, and you can see that ranged from about 64% in the UK to 78% in Germany. Similar patterns in the men with high risk of fracture, but disappointingly a large treatment gap in both sexes across the countries in EU6. The 129 study was a little bit more primary care based. So this was a study where women over the age of 70 attending their GP in the countries shown on the bottom of the slide here were asked questions about their risk factors for fracture. They were there for no particular reason related to fracture. Many of them were there for management of long-term conditions, for health checks related to hypertension and so on. And again, they were identified to be at increased risk because of high fracture probabilities, prior fracture, or if they had a bone density scan, if the T-score was less than -2.5. But it might not surprise you that only about 20 to 25% had actually had a bone mineral density scan. And again, the numbers are very comparable to the numbers that came out of the EU6 analysis. You can see that this is just in women over the age of 70, but you can see that in those identified at high risk, 53% in Ireland, which was the best performing, up to 91% in Germany, were not receiving any treatment despite that knowledge that these patients were at high risk of fracture. When I say knowledge of high risk of fracture, of course, that knowledge was available to us because we went to look to assess that risk of fracture. But that doesn't always happen in primary care. And in this 129 study, we were able to have a little closer look at what would be the impact of the GP having apparent awareness of fracture risk. And one of the ways that we could look at that was to see whether there was an osteoporosis diagnosis in the healthcare record. So on the left here, we're looking at the proportion of the population who were untreated despite being at high risk, and that's in our study about 75%. But if we look at those who had osteoporosis diagnosis in their healthcare record, compared to in the blue bars, those who didn't have an osteoporosis record, diagnosis recorded, then you can see in the patients with the diagnosis recorded, the treatment gap was 31%, compared to 94% in those who didn't have osteoporosis diagnosed. So it says in some regard, that the knowledge of high risk, and that translates into a diagnosis of osteoporosis in one way or another, was associated with an improvement in the treatment gap. So it's really not that we've got an awareness gap, a treatment gap, it's that we've got an awareness gap and a lack of diagnosis or a lack of uptake of the awareness to translate into risk assessments and identification and subsequently to treatment. Having said that, a 31% care gap in those with an osteoporosis diagnosis is something that still shouldn't be ignored. So that's really one of the biggest gaps that we recognize within the management of osteoporosis today. Of course, we have had threats, and we're used to many threats in terms of our healthcare resources, in terms of policy decisions about healthcare budgets at national levels and so on. But of course, over the last year, all of us have really been struggling with dealing with the COVID-19 pandemic. Some of you may have seen that we were able to go back and look at the impact of the COVID pandemic across the globe in terms of its impact on FRAX calculations arising from within countries around the world. And this slide we published a couple of months ago, looking at the weekly access or the weekly number of calculations on the FRAX website, and you can see these nice finger-like projections from the first 4 weeks in February through to the middle of March. The small arrow at the top here represents the pandemic being declared, and you can see that there's a very rapid and marked drop-off in the access to FRAX calculations online. Across the globe, this was in the region of about a 60% decrease. In Europe, on the right, you can see that some countries had greater decreases than others, reflecting the burden of that first wave of the COVID pandemic on healthcare systems across Europe. Globally, again, there was a fairly marked difference. You can see in the table on the bottom left here, we're looking at countries by global region, and you can see that within Asia, for example, the decrease at the peak of the reduction in Asia was only an average of 14% reduction compared to, for example, in Europe, a 65% reduction, and in the Middle East and Africa, a 68% reduction. And of course, we know that this probably has something to do with the way in which countries were prepared for a pandemic. Many of these countries in Asia had had prior exposure to previous scares and previous localized epidemics of coronaviruses and related viruses, and their systems were more rapidly able to adapt to the threat posed by the pandemic. And of course, here we are in Europe in the second wave of the pandemic, and it'll be interesting to maybe hear some of your views and to discuss how we're coping with that second phase of the pandemic. So I just want to summarize what I've presented to you. So the total number of fragility fractures in the EU6, which is the data that we have at the moment, is high, 2.7 million fragility fractures in 2017, and it's going to continue to increase, rising up to 3.3 million in 2030. That's going to be associated with a rate of increase in costs from about 38 billion to almost 48 billion in 2030. The treatment gap is large. It's almost 3/4 of women at increased risk of fracture are not on appropriate treatment, and that had actually increased from 56% in women in the first scope exercise in 2010. So there remains a need to increase awareness and facilitate identification of patients with an increased fracture risk. In these difficult times, I think it's important to remember that fracture risk assessment tools can play a significant part in guiding our decision making in osteoporosis. In the UK and in many other countries, we've had very limited access to bone mineral density assessments, particularly during the first wave of the pandemic. And that therefore stymied decisions about treatment and interventions being initiated. And that's something that we can bypass to some degree by the use of fracture risk assessment tools. Thank you very much, and I'll stop there and hand back to Nick.
Great, thank you very much indeed, Eugene. Okay, so we're open for questions, and do make use of the question box on your screen there. We have a couple of questions through already. So just to kick off then, what contributes to the smallest treatment gap being in Ireland in the 129 study?
That's a very good question that I don't have a good answer for at the moment. I think the the healthcare system, there has been I think a fairly strong, well-structured approach by people who care about osteoporosis and fragility fractures in Ireland to get enough government buy-in to seeing it as an acute, as a problem that needs to be dealt with. And I think there's been a greater awareness amongst primary care physicians as well. So there's been a good exercise in trying to improve knowledge and awareness, and that has worked to some extent. So I think that's the basis of it. Of course, many of us have been trying to do those similar approaches in our country and other countries without the same success. So it might be something that we need to go back and look at in some more detail to see what the drivers are. Are there financial incentives or other things that might be driving it? I'm not aware of the answers to that.
Great, thank you. So thanks to Magdalena Fleshberger for that question. And then moving to a question from Bente Langdahl. In the 129 study, was the outcome the same if patients had osteoporosis sort of compared with fracture mentioned in the patient file? And do GPs respond as well to fracture in the discharge letter as to osteoporosis? I guess one of the key fundamental things, are we about osteoporosis or are we about fracture?
Yeah, and I think that's an excellent question. I'm just trying to remember. It was difficult to compare, Bente, to some degree, because bone mineral density assessments were only available in 25% or less of the cohort. So to compare within that, whether it was fracture or BMD osteoporosis that was driving it is somewhat difficult. Having said that, I think the knowledge of the T-score did drive intervention more than the knowledge of fracture. I might be wrong on that, but that's my recollection of the data. But I think there was still about a 50% treatment gap in patients with known fracture, so that's still something. And I guess that just reflects practice. That we still have this drive across Europe that a lot of prescribing is based on that T-score of -2.5, and in its absence, access to treatment is more limited. And I think that's something that we need to continue to address, that there is more to fracture risk than that particular T-score.
Absolutely. Great, thank you very much. So I think that there's no more specific questions, but I'll just remind you that at the end of the session, we'll have chance for any further questions and perhaps a more general discussion of the landscape. So thank you very much, Eugene, and I'll now just introduce our second speaker, Dr. Joseph Blanch-Rubio from the Hospital del Mar in Barcelona, Spain, who's going to tell us about the influence of anti-osteoporosis treatments on the incidence of COVID-19 in patients with non-inflammatory rheumatic conditions. So, Joseph, are you able to share your screen?
Hello.
Hello.
Do you see my slides?
Welcome. I will disappear.
And the slides? Do you see the slides?
I see the slides, I see you, and the floor is yours.
Okay, thank you very much. It's a pleasure to be here, and good afternoon. First of all, I would like to give thanks to the organizers of this webinar for the opportunity that they have given to me to present to you the results of a recent paper that our team has published in the journal Aging with regard to the influence of anti-osteoporotic treatments on the with non-inflammatory rheumatic conditions.
Joseph, just to say that the signal's not great, so it may be you need to turn your camera off just to make sure the bandwidth is okay. Great.
Do you see me?
You're back again. It was more just that the sound stopped and the picture stopped temporarily. So I think if you keep your microphone on but turn off your camera, that should be safer.
Turn off my camera?
Yeah, turn off your camera. Perfect.
And again?
Yeah, and we can hear you fine now.
Okay.
Oh, you've turned back on, but keep going.
Okay, thank you very much. Excuse me for the delay. Okay, COVID-19 pandemics in Spain. Really, Spain was one of the more one of the country that has suffered one of the highest rates of COVID-19 incidents and death in Europe, mostly between March and April 2020. Really now, you can see on the left hand of the slide, the daily new rates in Spain. You see here a huge amount of dates in the first wave, and now you can see this is the numbers till October 10, but now we are in the middle of the second wave that also has a very big impact. As you can see, on the figures are related to the 3rd of May of 2020. Spain was one of the more severe affected countries in Europe. The total number of cases was more than 200,000, and we suffered 25,000 deaths. Really, it was a terrible situation, and the pandemic in Spain was very hard in those times. Well, with regard to probably you all are aware of this. This is the COVID-19 progression and inflammation. Remember that initially there is a viral phase, and after this viral phase, it turns onto an inflammatory and inflammation phase, where plays a key role the cytokines storm. That really, this is the cause that the patients die or has a severe illness. In this phase, the immune system seems to be dysregulated in the severe forms of COVID-19, probably due to an abnormal response by the immune cells such as monocytes, macrophages, and or dendritic cells. Well, with regard to DMARDs, it stands for disease-modifying anti-rheumatic drugs and COVID-19. No? Really, it seems that perhaps it's in doubt. It's still a matter of strong debate, but it could be that there are potential protective effects of some disease-modifying anti-rheumatic drugs, DMARDs, to treat COVID-19. Indeed, some patients are currently treated with DMARDs. For example, tocilizumab, saralimumab are used off-label in some cases for treat these patients. Our team, with respect of this, has recently published a paper in Frontiers of Pharmacology that shows that probably some DMARDs may have a protective effects on the incidence of COVID-19. Mainly biologic DMARDs, but also synthetic DMARDs. Well, in relation to the justification of this study, we tried to assess the possible effects of anti-osteoporosis treatments in the clinical expression and incidence of COVID-19. This really is not still known. The general recommendations of the main osteoporotic organizations in the community of Bonn recommended to maintain the anti-osteoporotic treatments, but these recommendations were only based on experts' opinion. There were no data about this, strong data about this. One of the insights that we had is that the rank-L system is involved in processes related to the immune system. We hypothesized that perhaps denosumab, a fully monoclonal antibody against rank-L that inhibits osteoclastogenesis, could modulate in some way the immune response associated to SARS-CoV-2 infection, no? And this prompted us to start an study about this. The methods of the study. The objective was to elucidate possible effects of anti-osteoporosis drugs, anti-receptive calcium and vitamin D, and associated treatments, analgesics and antidepressives on COVID-19 incidence and clinical expression. The population was the patients that were suffering from non-inflammatory anti-rheumatic conditions. We rule out all the patients that were suffering from inflammatory conditions. We only look at patients with osteoporosis, osteoarthritis, and or fibromyalgia. The population was about 2,000, more than 2,000 patients, 2,102, that were living in the influence area of a referral hospital in Barcelona city. And these patients had to receive care, have receiving care at the patient's rheumatology service of my hospital, Hospital del Mar, is a university hospital in the city of Barcelona for the last 6 months. You can see here to the right the map of Barcelona town, and in more dark color, you will see our area of influence. It's about an area of more than 300,000 inhabitants. The design was a cross-sectional study of the cumulative incidence of COVID-19 from March the 1 to May the 3rd, 2020. Hospital and primary care clinical history revision was performed. The outcome was the COVID-19 diagnosis, and the analysis was related to figure out the cumulative standardized incidence rate of COVID-19 in the study population for comparisons with the general population of Barcelona. We compare the data of our patients with the general data of the population of Barcelona city. Multivariate adjusted Poisson regression models to evaluate the association between different treatments and the presence of COVID-19. About the population characteristics, as I said, the study was performed in 2,102 patients. 85% of them were women. The mean age was 66 years old. 63% were suffering from osteoarthritis. 43% were suffering from osteoporosis, and 27% were suffering from fibromyalgia. With regard to comorbidities, 42% had hypertension, 50% pulmonary disease, chronic pulmonary disease, 14% had cardiovascular disease, and 12% diabetes. In relation to the treatments that these patients receive, and specifically in the patients that were suffering from osteoporosis, 12% of them were receiving denosumab, 8% of them intravenous zoledronate, 6% oral bisphosphonates, 23% calcium, 62% vitamin D, and 12% diazide diuretics. 58%, you have to keep in mind that these patients also were not only osteoporotic patients, but also patients suffering from osteoarthritis and fibromyalgia. 58% were taken analgesics, and 31% antidepressants. What was the number of diagnosis of COVID-19 in this whole population of 2,100 patients? 109 patients were affected by COVID-19. The crude cumulative incidence rate was 5.2%. With regard to the grade of the disease, of the COVID-19 disease, 57% they suffered a mild form of the disease, 14% a moderate grade of disease, and 27% a severe form of the disease. With respect to evolution, 65% remain at home, 22% were to be admitted in the hospital. Of the total population, 2% were treated with non-invasive ventilatory treatment, and 0.9% were to be admitted at the intensive care unit, and unfortunately 8% death. The cumulative age standardized incidence rate of COVID-19 was as follows. This incidence rate in the general population of Barcelona city was 3.69%. In our population, the patients with osteoporosis suffered at 2.98% of incidence of COVID. The patients with osteoarthritis had 4.58% of incidence of COVID, and the patients with fibromyalgia suffered an incidence of 4.45%. As you see, the population, the patients with osteoporosis diagnosis has a little bit less cumulative age standardized incidence than the general population of Barcelona. The patients with osteoarthritis a little bit high than the general population, and the patients suffering from fibromyalgia has also a slight increased incidence rate. When we look for the adjusted relative risk of COVID incidence, you can see in the chart that denosumab, zoledronate, and calcium has a relative risk of 0.58, 0.62, and 0.64 relative adjusted rate for COVID-19. Also, it should be mentioned that duloxetine, a dual antidepressant, has also showed a reduction in the incidence rate of COVID-19. The relative risk was 0.68. Pregabalin, in opposite, pregabalin, a treatment for chronic widespread pain for fibromyalgia, increase the relative risk to 1.55%. Well, we then use a statistical method that is called propensity score matching. As you know, it's a way to create a virtual comparative control group. In such this method, the propensity score matching, in the population with osteoporosis, as I said, it's treated individual with denosumab, biphosphonate, and calcium was matched with an treated individual with similar characteristics: sex, age, cardiovascular disease, diabetes, pulmonary disease, kidney disease, and cancer. Well, it's a way to create a virtual control group. And when we figured out the numbers, we saw that we found and almost equivalent estimates. For example, denosumab was the relative risk was 0.73, zoledronate was 0.55, and calcium was 0.72. It has to be mentioned that in all cases, all the confidence interval cross the one. Well, discussion of these findings, no? It seems that probably, I say probably, the exposure to denosumab, intravenous zoledronate, and calcium were associated with a between 30 and 40% decreased risk of COVID-19 in our study population. With regard to the potential mechanism of this effect, this potential effect, we hypothesize that RANKL inhibition due to denosumab modifies the immune cell profiles and probably decrease the activity of pro-inflammatory cytokines that might elicit beneficial effects during viral infections and could attenuate the hyperactivity of pro-inflammatory cytokines associated with COVID-19 progression. With regard to zoledronate, zoledronate is known that may make dendritic cells and their precursors be less susceptible to SARS-CoV-2 infection. It inhibits the prenylization of small GTPases, which might hinder endosomal exocytosis in the dendritic cells required for the advance of SARS-CoV-2 infection. With regard to calcium supplements, they may counteract the decreased serum levels of calcium promoted by SARS-CoV-2 infection, which may lead to an improvement of the immune cell response and attenuate the probability of infection progressions. These are the hypotheses that we set up to try to explain our findings. Limitation of this study, no? First of all, we now had information of osteoporosis rate, and we had in this way a potential confounding effect by the indication. This means that when the clinical indication for selecting a particular treatment also affects the outcome. But as I said, through the propensity score matching, similar RR estimators was found almost the same. This study should be recognized that is a cross-sectional design with all the limitation that a cross-sectional study has. No, data were collected also by many medical researchers or clinicians that review the medical history. This can put a little bit of some kind of confusion, but we try in opposite of this. This is a relatively large sample size, more than 2,000 patients, and we perform meetings with all the investigators to try to unify and set up a clear classification criteria. We included patients from a tertiary hospital that probably has had a more severe force of non-inflammatory rheumatic conditions than in the general population. I have to say that in Spain, all the osteoporotic patients are covered by the Insurance National Service. These rule out any kind of bias due to the availability to get the medications. almost all the drugs are free for all the Spanish citizens. And with regard to limitation also, and finally, the COVID-19 asymptomatic patients were not detected due that in those times, at the start of the pandemic, the tests for diagnosis for the diagnosis of COVID-19 were very scarce in our country. Well, as conclusions, I can say that the main treatments currently used for osteoporosis are not associated with an increase in COVID-19 incidence. In contrast, and with the limitations that I've told you about before, a decreased incidence of COVID-19 was revealed with two anti-resorptive drugs, denosumab and zoledronate, as well also with calcium treatment. In conclusion, our data are consistent with a lack of direct relationship between osteoporosis therapies and COVID-19 incidence, providing, in our opinion, a scientific evidence in support of the recently published guidelines by the ACR, EULAR, ASBMR, and IOF to maintain anti-osteoporosis treatment for COVID-19 patients, which were based solely on expert opinions. Many thanks for your attention. I'm open to any questions. Thank you very much.
Thank you very much indeed. That's a really interesting study, and I mean, I think you alluded to some of the considerations with the study design and the limitations in this sort of very sort of patient-based data, where you have, I mean, these are not sort of a million people in a data set where you can really use the propensity matching in a very rich data set. And I think your last conclusion that there's no evidence of increased risk with osteoporosis and treatment, I think is really helpful and certainly consistent with what the guidelines and what else is out there. I guess the sort of headline thing that might be of interest to people particularly was this suggestion that there might be a protective effect of those three treatments, and I think there it's just important to bear in mind, as you said, that the confidence intervals spanned 1, and that there were these issues of confounding by indication and so forth, which you can't completely remove in this setting. Was there anything further just to say about that aspect and about the sort of clinical message that comes from this?
I would say that first of all, I think that the main idea, main conclusion is that you have to keep the given anti-osteoporotic treatments to our patient in this pandemic. I think that is the main result of our study. It seems that anti-osteoporotic treatments in the COVID-19 pandemic, the current pandemic, has to be maintained. I think that is the most important message, no? The other, I think that probably the denosumab may have a potential beneficial effect, but it's a potential one. If we want, whether we want to know this, it will be necessary to carry out studies with a much more bigger population, no? The same for zoledronate and the same for calcium, no?
Yeah, agreed. I mean, I think given what's at stake from suggesting that something is protective against COVID, then I think really we need the highest levels of evidence to be sure about that, and of course that's ideally randomized controlled trials before any change in recommendations. So we're just a few questions coming through. So Bente Langdahl, thank you for more questions. We have were you able to uncover any differences in attitude towards the COVID precaution? For example, the recommendations like isolation, face masks between the 3 patient groups. Any differences in social status? Were the osteoporosis patients, for example, shielding themselves, self-isolating more than the general population?
Really, we don't assess for this, but we are working in our area of influence. It's a medium lower class population. The general recommendations for all the people for equal for all our population, but we don't know for sure if the patients suffering from osteoporosis were more shaded than the others. We don't know this. We don't know this. But you have to keep in mind osteoporotic patients, osteoarthritic patients, and fibromyalgia are people that in general has a very similar profile. In general, patients that don't move a lot, remain at home frequently, and probably there will not be a great difference with regard to shielding against the COVID-19.
Great, thank you. So that just briefly, because I'd like to bring Eugene back in just in the last 5 minutes for some general points, but questions, Dr. Friederike, Thomasius, about raloxifene, were you able to consider that? And then parasults for teriparatide. Did those 2 treatments figure in the study at all? So did you find any, were you able to look at any effects of raloxifene or teriparatide in your study?
No, we didn't find effects of teriparatide and raloxifene. Probably due to that the number of patients in our population that were receiving these 2 drugs were very few, and probably the results doesn't have enough power to show any kind of difference.
Okay, thank you. So that's great. Thank you, Joseph, for that presentation. And then just in the last few minutes, I just had some sort of closing thoughts that we might like to reflect on in terms of the impact of the pandemic. And really, we're in the sort of, well, I suppose 3rd wave in the UK. Things are not looking good generally around the place. And I just wondered if you could each just give a few thoughts on the impact on services this time round as opposed to the 1st wave. And I mean, is there any qualitative difference? Are there differences in what we're trying to do and what we expect and how we're managing to cope with it in terms of keeping our osteoporosis services open? Eugene, do you have thoughts on that first of all?
Yeah, I think there certainly are differences. I think that really the 1st wave was characterized by sort of complete lack of preparation, and it wasn't just the intensive care and other beds that were swamped. It was basically that all services were not swamped by the pandemic itself, but swamped by the advice and response to the pandemic. So there was really a total marked shutdown in lots of healthcare, lots of very strong messages, and people didn't really realize what we were dealing with, but lots of strong messages about shielding and staying at home. And obviously our population at risk are very much in the at risk for COVID population. So there were people reluctant to come to hospital, people were reluctant to and go to see their GP. Bone density scanning, as I mentioned, was really stopped as part of the approach to just reduce visits to hospitals, and hospitals were seen as sources of COVID infection, really, rather than places to go for treatment. So I think the second time around we're much more prepared in terms of the facilities that we put into place with distancing, PPE, cleaning protocols, separation of appointments, and so on. So we are keeping the scanning going, but it's not anywhere near back to the normal sorts of levels. And there still is a backlog of scans that we need to continue to work through. And my concern is that, you know, that fracture risk doesn't get put on hold for 6 months, and we can deal with it 6 months down the line. And people who are going through and fracturing and other high-risk patients, they do need to be managed. And I think we need to embrace the other management strategies, that we just don't sit back and say, I can't get a bone density scan done, so I can't manage your osteoporosis. We can manage osteoporosis. We know that patients at high risk of fracture respond well to the appropriate osteoporosis treatments. And I would much rather that patients were assessed for risk, started on treatment, and of course their bone density can follow at some point down the line if that's still seen as an absolutely essential component of management. So, but I think we're doing better. Our services have remained open. We're doing much more remotely, and I think both myself and my patients are getting used to it. I'm not using video conferencing as much with my patients as I possibly should be, but they tend to be an elderly population, and the telephone seems to work reasonably well. It's far from satisfactory because you don't get the same depth of interaction. You can't see the patient, you can't see how they're moving, and most of them are just so grateful for the telephone call that they brush their symptoms to the side and don't really go into depth.
Yes, agreed. Great, thank you. And just in the last couple of minutes, Joseph, any further thoughts on this time round and keeping services going and that sort of thing?
Yes, I concur completely with the Eugene ideas and insights. No, it happened the same in Spain. No, in the first wave, we are unbelievably unprotected. Our the staff members and the hospital and whatever was a almost complete disaster. No, was a kind of war medicine. No, but the second wave was different. We are much more prepared. We are visiting patients in our patients' clinics. And but one important thing, and I think that this will remain forever, will be the telemedicine. We have realized that more or less 80% of our visits could be done through telephone or telematic one, no? And yes, it's true that many of our patients are old people and they are not able to get online through the computer, but the telephonic works. It works, and perhaps it's not the same that a standard visit, but the telephone visit, it's very important for us. At least we are now doing more than 80% of our visits through the telephone or through the computers in a telematic way, no, a kind of telemedicine. And I think that this will remain. No? This allows us to have a little bit more time to do other things. No, it's good also for the doctors, and it's not so bad for the patients. No, really, I should recognize that the personal visit, the face to face, has a lot of advantage, but this kind of telemedicine, I think that will remain. We are moving in this direction. No, we are now doing also DEXA scans and whatever. No.
Great. Well, thank you very much, and I agree. I think a lot of these changes are here to stay, and I think now it's about making the best of it and how we can keep a sort of humane face to medicine despite sort of technology and the remoteness, and really continue to do the best to our patients going forward. So With that thought, I will just thank you again, Eugene McCloskey and Joseph Blanche-Rubio, for your excellent presentations. Thank you very much to Emma and Dominique for facilitating. Thank you to Amgen for sponsoring, and thank you to all of you for listening, and I hope you have a great weekend and join us for the next Bonecast webinar in due course. Bye.
Thank you very much, Professor Harvey, and thank you to all of you for your participation in this webinar. We really hope that you enjoyed the session. We will be posting a recording of the webinar on the IOF website, but you will also receive a link to the recording by email on Monday. You will also be prompted to fill in a survey immediately after the webinar. We would appreciate your input and comments as we continuously try to deliver webinars that will meet your needs. And last but not least, if you have any questions or comments, please don't hesitate to send them over to webinar@iofbonehealth.org. Thanks again, Professor Harvey, for chairing the webinar, and of course to our excellent speakers, Professor McCloskey and Dr. Blanche-Rubio, and have an excellent weekend, everyone.
Thank you very much.
Thank you to you.
Bye.
Thank you very much. Bye-bye. Good weekend.